Thank you for being here today. My name is Hafiz Alsmaan. I am one of the Nephrology Critical Care Fellows. And guess what? We're going to be talking about urine and hyponatremia today. First of all, thanks for Dr. Yi for supervising this presentation. I have no disclosures. In the beginning, I'm going to just start by saying a couple words and some introduction about the arginine vasopressin. It's a human-made hormone resembling the normal hormone we have in our body, ADH, with little bit some differences. The biochemistry for it is a little bit different. The DDAVP different than the one we generate in our body by the last nitrogen binding there. Has a lot of functions to do in the body: blood flow, volume control, kidney function, and regulating how the water handled in your body. A quick kind of historical background about it. It was discovered in 1895 by George Oliver and Edward Schaefer in London. Both of these two big scientists also they discovered adrenaline at that time. We were able to manufacture this in Chicago, Illinois. Dr. Devenier, he get Nobel Prize for discovering and manufacturing the vasopressin. Dr. Tatum said, don't kill us with the equations. I decided to do that with different way. This is the vasopressin signaling network, how it works in the body and how regulated. Stay calm. I'm gonna be done in no time over here, so I'm gonna be out of here shortly, so just be patient on me a little bit. To be more simple, vasopressin has the major trigger for vasopressin in our body is really the volume status. The minute we have a volume loss or any kind of a trigger in the body towards a volume loss, right away the vasopressin, the vasopressin, or ADH produced. I would like to mention something a little bit as a difference between the ADH we make in our body and the vasopressin we give to the patients. The ADH doesn't have that much influence, the one we generate, doesn't have that much influence on the blood pressure comparing to the vasopressin we are given through, artificial way, IV or, as medication. And it works on two receptors. V1 is the one responsible to increase the blood pressure, and V2 responsible for the renal control of the water handling and the sodium handling. On the level of the kidney, the urine max urine concentration happen in the loop of Henle over here, but the ADH works on the distal collecting duct, and it do that through a couple kind of mechanisms. First, the AVP get attached to the V2 receptor, and through CAMB, this receptor get incorporated inside the cell, aquaporin 2, and we get absorb more water. Aquaporin 3 and 4, the other ones on the other side. And between these cells and the tight junctions, even these kind of tight junctions, they open up to get more water in your body to help you control or hold more volume in your body in response to the hypovolemia we have. Neeraj gonna be presenting more detailed clinical case, but I gonna just throw a scenario just to tell you that this is something we face very much on, if not daily basis, at least once or twice a week. 78 years old female coming from a nursing home, dementia, hypertension, CVA. She's on aspirin, hydrochlorothiazide, Aricept, admitted to the hospital, fever, hypertension. It's a sepsis, severe sepsis from UTI, hypovolemic hyponatremia, sodium 115. You resuscitated this patient, 3 liters of normal saline, blood pressure improved, didn't require any pressors, and the sodium start going up 119, and slowly, and over the next 10-12 hours, the patient start opening up, making a lot of amount of urine, 300 to 500, 350 milliliter an hour, and the sodium start going up high. I think it's we are very familiar with these scenarios. They happen a lot with us. And basically, it's a kind of a response we see when the ADH gets shut down after satisfying the volume. So I want to just to mention a couple words about the autocorrection of this in serum sodium. What the kind of the situations you have autocorrection of serum sodium. Administration of saline to the patients with the true volume depletion. That's the normal kind of thing. Your ADH gonna be shut down, so you have no more control on water handling on the kidney level. So you start peeing free water very much, and the sodium start going up higher. Discontinuation of drugs that cause SIDH like SSRIs. Discontinuation thiazide diuretics, they interfere with urine dilution. Spontaneous resolution of transient causes of SIDH, pneumonia, nausea, surgical stresses. Also, if tolvaptan, if in the age of tolvaptan these days, if we stop that, you can see kind of rise, such kind of rise in the sodium. This is kind of a subject really opening a lot of argument about how the way we look at the overcorrection of sodium. Are we truly considering this an emergency need and attention? I'm sure and I'm positive many of you gonna mention many cases you saw over your experience. A lot of overcorrection happen, and really no clinical kind of complications or problems. This is a kind of a review by Dr. Richard Stearns. You're going to see this name a lot. Dr. Stearns from RGH from Rochester General Hospital, very much dedicated his life for hyponatremia studies. Based on the expert opinion in this field, the consideration for the overcorrection of hyponatremia, yes, it's a true emergency, and we should be really careful about that. And again, the argument can go on and on and on that is really overcorrection of the sodium beyond certain numbers. It's a problem, not a problem. But all very much everybody agreed that you see a lot of complications with the chronic hyponatremias more than the acute. That definitely. And the acute hyponatremia, if something if the hyponatremia happen in the 24 hours. But as much as you have a chronic hyponatremia beyond 2-3 days, this is the area where it becomes risky, and especially if the rate of the correction increase up to more than 20 milliequivalent a liter in 24 hours, or overcorrected above 140. On the other hand, the argument, the osmotic demyelination syndrome is really rare. You don't see it that often, and yes, it's rare, especially in the chronic hyponatremic patients. If the serum sodium concentration increased, if you respect that range between 9 to 12, rarely you're going to be seeing such kind of thing. We are not anymore here talking about hourly rate of correction. That out of the picture completely. Now the concentration is really about the 24 hours and 48 hours. 9 in the first 24 hours and 18 the total 48 hours. Even though with this, there is case reports about neurologic complications happen even for a patient being corrected in that kind of range 9 to 12. So really now the notion from the nephrology standpoint, and definitely making that step over to the critical care, it towards more conservative type of approach than before. So really the advice is to go even less than 9 or even 8, and that's basically an expert opinion from many kind of big names in nephrology. Always this question comes from where this ranges, we get to know about these ranges. There is a good kind of literature, at least I pulled up for you 6 or 7 articles from where that kind of range of hyponatremia correction coming from. There is the problem in there, you have no kind of control the study you can do, all of it retrospective kind of thing. expert opinions, case reports, and all such kind of thing. And from my position on this presentation as supporting using the DDAVP, the argument in here really, what are we arguing about if we we can have complication with such kind of thing? I think being liberal on it really is not gonna give us that much of advantage comparing to being conservative with it and go slowly on this matter. The best article you can really find, barely, you're talking about 20 patients. This is a project or a study published in the Clinical Journal of American Society of Nephrology. This is also came in from Rochester General Hospital. You see Dr. Richard Stern's name there. They reviewed their cases. It is retrospective chart review for all patients given DDAVP during treatment for hyponatremia over 6 years period of time. 528 bed community teaching hospital. Barely they were able to find 20 patients over 5 years. So they divide these folks over two groups. Group 1, they have 6 patients. They were given DDAVP after the 24-hour limit of 12 millimole correction already reached or exceeds, to prevent any further overcorrection in the sodium over the next 48 hours. And they were able to achieve that in 5 out of 6 in there. The other group, 14 patients, they were given DDAVP in anticipation of overcorrection. And this is more and more type of, you see more and more type of a practice. I'm talking about the second group in there. When we go there and we are expecting we are seeing true hypovolemia, and you are resuscitating your patient and the patient start getting high urine output, many more and more nephrologists, they are jumping in and go and use the DDAVP even before reaching any kind of overcorrection numbers in there. In all 14 patients treated to prevent any kind of overcorrection, they were prevented from exceeding either the 24 or 48 hours. The point they are trying to make over here, that using the preventive way or preventive use of the DDAVP, it's helpful, it's controlled, it's safe, it's not making any kind of major complication for these patients. In all 6 patients in the group 1, 5 of the group 2, and 5 patients in the group 2 patients, the sodium, they've been plasma sodium concentration, they've been re-lowered actively to be able to control that kind of overcorrection in there. There is no serious events at all. Nobody end up with any kind of damages or neuro damages. There is one patient in this study died from a massive shock. That's all. And all of them, they've been discharged without any kind of neurologic deficits. That leads us a little bit about the concept of re-lowering the sodium. Is it really something relevant, something helpful or not helpful? There is a lot of animal studies you can talk about them, all of them in rats very much, about re-lowering the sodium, improving the sodium after overcorrection, if it can make kind of a difference for this, if it can make a difference. This is a very well built study published in Kidney International. The models, the rat models, sodium was less than 115 milliequivalent for 3 days. They were rapidly corrected, 25 milliequivalent and more. The rats treated with therapeutic re-lowering sodium, all of them survived without any neurological signs. In contrast, all control rats died or developed neurologic signs, hyperirritability, seizures. So this model showed really a benefit from re-lowering the sodium. The argument here, they are rats. Some of us see them cute, some of us see them gross. And some of us probably they were having a little bit unpeaceful hobbies way back. And you are absolutely right. human data is limited on this. There's observations, about the visibility of sodium relowering, but really, do we have any kind of evidence to support that if relowering the sodium gonna be more helpful than just watching these patients? And if you improve this, if you relower the sodium, are you able to really resolve the neurologic deficits or neurologic signs or complications that can happen from the osmotic demyelination? Case reports, you can't really see any kind of case series, you can't count on. This is from up to date. This is a patient, I think Maryland. Patient was overcorrected. We're talking here about this is days, this is the level of the sodium. Patient started with 106 sodium, was overcorrected, 129 you can see in 2 days, so high rate of correction in there. And after that, the neuro symptoms, they start to appear. And this is also something we'd like to emphasize, that the neuro complications from overcorrection of the sodium, they don't happen right away. They may take 2 days to 7 days really to appear. And in this case, they relower the sodium down again to respect these rules of not more than 24 hours. Not more than 9 in 24 hours, and not more 18 milliequivalent in 48 hours, and all of the neurologic symptoms and deficits, they gone completely. Again, case reports. I'm not gonna talk too much about the regimens. Neil is gonna cover part of the dosages and all of that, but there is kind of two approaches you can do over here if you want to use the DDAVP. The first regimen, you are using 2 mcgs each time. Max single dose for such kind of thing is 4 mcgs only every 6-8 hours, and you go and you watch your sodium in there. In case the sodium relowered a lot with this kind of maneuver, hypertonic saline gonna need to be used. The other approach, which I think it's much safer and much appropriate, by going ahead and give these patients 1 dose and go ahead and follow on it and watch your patient, and to making sure if you need, you can repeat again the dose if needed in there. What I would like to emphasize about that, yes, hyponatremia overcorrection is an emergency. Rate of correction less than 9 milliequivalent in 24 hours and 18 milliequivalent in 48 hours should be respected. Conservative approach in this, really the risk doesn't worth it. DDAVP can slow down the sodium overcorrection. It's safe as much as taken serious. You can do such kind of thing, therapy, and just hope for the best. These patients need close monitoring, their hemodynamics, their chemistries, urine output, and act on it appropriately. And I know how much many times we have trouble getting our blood work on time. You want to use this therapy, you need support with it, you need to keep your eyes very close on it. It's safe, and really, again, by the end of the day, really doesn't worth it, taking that risk for overcorrection, even though you didn't see any kind of case in there. So, viva DDAVP.
The other part of today's talk is to talk about the cons of DDAVP. So we heard about the pros initially. So before we continue though, I want to talk a little bit about the pathophysiology that us intensivists can understand. It's a little bit different than what Hafiz was referring to. I'm going to talk about the pathophysiology in acute hyponatremia, what happens. So if we look at this dark line here, that's a brain cell. And within the brain cell there's water and there's particles. And those particles are basically potassium and organic osmose. That's what constitutes the osmolality within the brain cell. Outside here, in the extracellular space, we have water and sodium. And in acute hyponatremia, when that sodium level goes down, the water shifts to the intracellular compartment. And when that happens, the brain cell swells. And you can see that by the dotted line here. And when that happens, we have cerebral edema. So in cerebral edema, the patients present with nausea, vomiting, headaches, seizures, and even herniation. But if that goes on for 48 hours, then we have chronic hyponatremia. That's it, just 48 hours. And that's because the situation has now changed. The brain cell actually has the ability to pump out the potassium and organic osmose, reducing the intracellular osmolality, down to what the sodium outside was. And so the water shifts back outside, this enlarged cell shrinks back down to what its normal size was. And so the brain's doing better at this point. But now you're left with hyponatremia. So 48 hours have passed, patient's admitted to the hospital, ICU fellow comes along, sodium is in 110, changes it to 140 in 12 hours. By doing that, the water from this brain cell is now going to come out of there, because this is where there's the increased osmolality in the extracellular space. And what's going to happen is that cell is going to start shrinking and subsequently undergo osmotic demyelination. And so that's the process. The chronic hyponatremia is really what we're worried about. If we correct that too fast, it can potentially cause osmotic demyelination. So this pathophysiology is pretty straightforward, right? You'd think that we'd see it pretty often because we tend to correct pretty fast sometimes, but yet we don't. How many people in this room have seen osmotic demyelination? Put their hands up. 2 people. 2 nephrologists.
I've seen it, and I can say it's real, and I've seen it, I can tell you where. You stop it if you want to record.
We'll talk about it in a moment.
Okay,
So
we'll talk about it's real, and you don't see it because you send the patient to another floor or a pod, and the patient comes back mute. And we call neurology, nobody knows, and then after everybody exhausts the differential diagnosis, we go in the chart, and you see that this patient's sodium was correct. So it can happen.
Okay. What about Dr. Yi? What case have you seen?
A patient with cirrhosis was treated aggressively, and it occurred a little late, 7 days later. Actually, you can describe everything second by second when it occurred. Nothing for essentially 6.5 days, and then he was akinetic and paralyzed ×4. Unbelievably, he recovered enough to do it again.
So you've seen one case. How many cases have you seen, Dr.
I've seen one case.
One case. Okay.
That's enough, though.
Sure. Not arguing.
If it's something potentially avoidable easily.
I agree.
Well, let's let him go ahead and talk. We can knock it out. He's separate.
So let's talk about your experiences. You've practiced ICU care for 50 years, Dr. Quality another 50-pack years of practice, Dr. Let another 50-pack years of practice. How many cases did you guys see? Said none. How quickly in your practice, when you were practicing, were you correcting the serum sodium in your patients?
You know, back when I was doing ICU more than a decade ago, for over 25 years, we used to correct pretty freaking rapidly. And unlike, you know, what you're describing, I would follow my patients, you know, here in the hospitals and everything. When I treated them, they were my patients. I'd see them in the hospital, I'd follow them until they get back in the clinic, go long term. So, like I said, I used to correct them pretty rapidly. So.
And yet, no cases.
Yeah.
So, how often does this actually occur? Well, hyponatremia is a common disorder, and same with hypernatremia. I mean, half of our patients up in the unit have one of those 2 disorders. Keeping their sodium between 135 and 145 is honestly pretty challenging. And so hyponatremia is common, but we don't see a lot of osmotic demyelination. And because of that, the prevalence is really unknown. There's only been 54 cases in literature since 1997 to 2012. And that's why the data and recommendations are really based on case series rather than any randomized controlled studies. So where did we get this? We need to correct to 8 that Hafiz was referring to, or some people are even saying only 4 to 6. It's basically because historically in the 1950s they found some cases with something that was going on in the brain. In 1970s they were able to say that, well, this was due to hypernatremia or hyponatremia being corrected rapidly. And then it wasn't until like the 80s where they started putting a bunch of case series together, and then they said, well, you know, if we corrected more than 25 in 48 hours, it leads to patients putting them at risk rather for osmotic demyelination. So correct slower than that. Then in the 90s they said, well, 18 to 25 causes it, correct slower than that. And then there have been case reports in 2001 that said, well, they had osmotic demyelination even if they corrected at 10. And I was talking to Dr. Yi, he said he's even read case reports of one patient that was corrected to 6 and had osmotic demyelination. So 6 in 24 hours, really, that's nothing. So we've always been told to correct slowly, but what is slowly? The recommendations over the last 30 years have changed drastically. They just keep getting tighter and tighter and tighter, and this is just based on cases that occur. There's really no randomized control studies on this stuff. And basically, if we look through the recommendations in kind of the 2000 area, we've been sticking around the 8 to 10 or 4 to 6 range. And that's what's been going on since then. So I don't have any major randomized controlled trials to show you. But I do want to talk about some other trials that have documented increases in sodium and their outcomes. So this study was done in 2007. It was, the objective was to assess when treating hyponatremia with hypertonic saline if there's adherence to previously published guidelines of limiting the correction to less than 12 per day or less than 18 per 48 hours. That was the recommendations in 2007. The study group consisted of mainly chronic patients of 76%. There were some acute cases of 24%, and some of them presented with seizures and others were unresponsive or somnolent. This was a retrospective review of 62 cases over 5 years at one hospital. This is how they displayed the results. So at the bottom here we have serum sodium prior to the infusion, so that was basically their admission sodium level, and then the rise in serum sodium over the 48 hours. And so the first thing that the authors noted was that the patients that had really low serum sodium on presentation tended to correct much faster than the ones that were near normal. Also, there were some patients that did overcorrect in their series. So if we look at their actual results, the average change in serum sodium during the first 24 hours was about 7.1, and in the subsequent, overall in 48 hours was 11.3. The overcorrectors, there were some, so 11% in 24 hours, and then about 10% in about 48 hours, but still no cases of osmotic demyelination. So even though there's overcorrection, we really don't have it in any of these studies that were done. The other objective of the study was to determine the predictive accuracy of the formula used to calculate the change in serum sodium. This is a formula suggested, and basically can tell what the serum sodium is going to be after infusing sodium, normal saline or whatever you're using. And they concluded that if the serum sodium was less than 120, the actual increase in serum sodium concentration exceeded the expected rise in 74% of the patients. So they recommended not using this formula. And that's how their patients were overcorrected. So let's look at another study. This one, the objective was to compare IV saline versus fluid restriction for the treatment of chronic symptomatic hyponatremia. They had 53 patients. They were postmenopausal patients over an 11-year period, and they included patients with symptomatic hyponatremia. That means a sodium of less than 130, and all these patients had symptoms. Either they had some nausea, vomiting, or they had seizures, or they had falls with orthopedic injuries. And hyponatremia lasted for more than 48 hours, and that was confirmed by 2 separate lab draws. This is a prospective, non-randomized study, and the authors basically let the admitting physician treat the way they wanted. You do your thing, and we're just going to monitor and document. The people that wrote the study were involved with group 1, otherwise they weren't necessarily involved in all the patients. So they broke the patients up into 3 groups. So if we look down here, I'm not sure if you can see it, but group 1, which is right here, they broke into group 1, 2, and 3. So group 1 was given IV sodium chloride, be it hypertonic or normal saline, before any respiratory insufficiency. Group 2 was given after respiratory insufficiency, so all the patients in group 2 were intubated, and then they were treated with trying to correct their sodium. And then group 3, again, all the patients had respiratory compromise, and they were all intubated, but in group 3, they treated only with fluid restriction, no saline. And so they were looking for serum sodium changes, obviously, but the other outcome they were looking for was neurological status. So they graded patients on a grade called CPC, Cerebral Performance Category, from a grade from 1 to grade 5. So grade 1 is normal neurological status, and then on the other spectrum, grade 4 is persistent vegetative state, and then grade 5 is death. And so they were looking to see what neurological changes happened in these patients. And if we look at group 1 here, these were the patients, again, all of them had some neurological problem at presentation. They were all symptomatic. But if we look in group 1, the change in serum sodium was 22 over 35 hours, much higher than the recommendations that we're following right now. But none of them had any neurological problems at the time of discharge. Some of these patients even had MRIs done at a much later date, almost 4 months later. No evidence of osmotic demyelination. Group 2, they had a change in serum sodium of 30 in 41 hours. They didn't do so well. And the authors felt that this was due to the cerebral edema caused by the acute hyponatremia rather than the correction itself. They did do MRI on some of these patients also. Again, no osmotic demyelination. Group 3, that's the group that did the worst. All these patients that did have respiratory compromise, and they were treated only with fluid restriction. You can see here that there wasn't a huge change in the serum sodium, and 10 patients died within 24 hours. 3 other patients were institutionalized because of a vegetative state, and their CPC score was pretty high. And when the authors were looking back in the documents, a lot of the attending physicians that treated group 3 treated that way for one reason only. They were worried about osmotic demyelination, so they didn't want to correct too rapidly, and they stuck with fluid restriction alone as a treatment of choice. So clearly authors documented that that's not a good option in these patients. So it leads us to the question that correcting too fast is not good, correcting too slow is not good. So what is safe? So Dr. Stearns, as Hafiz was referring to earlier, that he's written a lot of the recent literature about hyponatremia and has written articles almost on a yearly basis in different journals talking about hyponatremia in different situations. In 2009, he wrote, "There's no therapeutic limit that's absolutely safe, and guidelines are derived from relatively small number of patients, and they can only give us a rough estimate of correction rates associated with an unacceptable risk of harm." So what do the guidelines say? So before we go to the guidelines, though, let's review how guidelines are made. So they're made based on the grade criteria, and recommendations are either graded as 1 or 2 based on whether they're strong or weak. And then we look at the quality of evidence behind that. If there's strong quality of evidence or there's very low quality of evidence behind that, and they're given a recommendation. So in 2014, numerous subspecialties in Europe got together and made recommendations, and they called it the Clinical Practice Guideline. This was published in the European Journal of Endocrinology, and in that they recommended limiting the increase in serum sodium to a total of 10 milliequivalents during the first 24 hours and an additional 8 millimoles during every 24 hours thereafter until the serum sodium reaches 130. But this is where it's important. The recommendation is 1D. They don't have evidence for this. Okay? They're just going by prior case reports or what people have written before. Some authors have talked about high-risk categories. This was from a neurology journal where they reviewed cases of osmotic demyelination, and they found out that alcoholism and malnutrition were very high up on the list for the patients getting osmotic demyelination. Their theory was that those are the patients that were unable to create those organic osmos within the brain cells at a reasonable rate. And so even though we were correcting at a slow rate, they weren't able to keep up. And because of that, they suffered from osmotic demyelination. They also found that patients after prolonged diuretic use were at high risk, and post-liver transplant patients were at high risk. And that was well recognized secondary to the cyclosporin causing hyponatremia. And so maybe we can start focusing on these patients in the future. But it's hard to tell because we don't have enough cases that we can say that this is definitely a high-risk category and these are the patients that are going to get it rather than the general population. So unfortunately, we're not there yet. So now, what if we do overcorrect? Our goal is 8 to 10 per day, but what if it is 18 by the end of the first 24 hours? Then what? So that's known as overcorrection. And this is exactly what Hafiz presented a few minutes ago when he said that overcorrection can happen basically in 4 different situations. When you're volume resuscitating a hypovolemic patient, and that's the same case that Hafiz presented. So when you're volume resuscitating a hyponatremic, hypovolemic patient, they're going to have a high level of ADH initially. And at some point when you volume resuscitated them, their ADH level is going to fall, they're going to start urinating, and at that point the serum sodium can go up almost 2 milliequivalents per hour. So when it's rapidly increasing, it's going to lead to overcorrection. Other situations include discontinuation of thiazide diuretics or drugs causing SIADH, cortisol replacement and adrenal insufficiency, or spontaneous resolution of the SIADH. So until now, in these cases, we've been using D5 water, right? If they corrected too rapidly or they did too much sodium shifting in one day, the recommendation was, all right, we'll give them D5 water, slow it down. But a lot of nephrologists felt that that was cumbersome. You have to constantly be checking their urine output. You have to keep checking their urine light, urine osmolality. You have to keep checking their serum sodium. You have to keep readjusting your calculations. So that's where DDAVP came in the picture. So then some authors said, we'll start using DDAVP and we can just slow down the rate of urination. So it's used as a dose of 1 to 2 micrograms IV for the antidiuretic indication. It should be done with fluid restriction, and it's contraindicated if there's a creatinine clearance of less than 50. That's according to the manufacturer, but I still think it's used. So side effects, just like any drug, it can cause an allergic reaction, cause anaphylaxis, seizures, flushing, headache, dizziness, or even hypertension. But what's the evidence behind using it? So this is the same, unfortunately this entire presentation is very redundant for you guys. This is the same thing that Hafiz presented. So this is DDAVP is effective in preventing and reversing inadvertent overcorrection of hyponatremia. This study group was a retrospective chart review of patients given desmopressin during the treatment of hyponatremia over 6 years at a single center. They included 20 patients, and the first 6 were given DDAVP to reverse overcorrection, and the others were given to prevent overcorrection. And I want you to focus on the last 2 columns. Those are the results that are most pertinent to our talk. They talk about this change in serum sodium in the first 24 hours and then change in serum sodium at 48 hours. And if we look at the top 6 patients here, that's group 1, and you can see that those are the ones that they were trying to prevent or actually reverse the overcorrection. And you can see that at 48-hour mark, a lot of these patients were under 18, which was their goal. And for the most part, they reached that and they prevented any complications, or in their mind, they did. In group 2, these patients were correcting rapidly and they were given DDAVP so as to not overcorrect in the first 24 or 48 hours. And for the most part, they were able to. And so they reported that none of the patients had osmotic demyelination, none of the patients had complications, and that DDAVP is relatively safe in this situation. But unfortunately, we have nothing to compare to. We don't know if these patients were going to get osmotic demyelination. We don't know if these patients were going to have complications. We don't know if it improved outcomes. All we know is that the drug works. The same author took that same concept one step further in 2013. This is also a study done by Dr. Richard Stearns, and said, you know what, instead of chasing the serum sodium, let's just create a controlled environment. Let's not wait till it suddenly goes up or wait till it's suddenly rapidly changing. Let's give DDAVP from the get-go and treat the patients with hypertonic saline so that we have a controlled environment and that we can have an expected rise in serum sodium. So at this point, he took it a step further, and if we look at the first 24 hours and then the second 24 hours, there was an average rise of serum sodium in the first 24 hours by 5.8, and in the next 24 hours by 4.5. And they documented that, saying that, well, giving DDAVP in hyponatremic patients and treating them with 3% hypertonic saline is safe, predictable, and that's what we should practice from now on. But again, we don't know if this improves outcomes. We don't know if this improves mortality. We have nothing to compare to. This is just a retrospective review of 25 cases that were practiced at a single center. So what do the guidelines say? So going back to the same guidelines that I was talking about earlier, published in the European Journal of Endocrinology, they recommend consulting an expert, keyword here is expert, to discuss if it's appropriate to add IV desmopressin 2 micrograms with the understanding this should not be repeated more frequently than every 8 hours. Again, 1D, very poor. They don't have any data behind this. So can we cause harm by giving DDAVP? Potentially. It can potentially cause hyponatremia. Now, there haven't been any reported cases or a lot of documentation in adults, but in children there have been. So there have been numerous case reports of children going to the ER with change in mental status and found to be hyponatremic. Children use DDAVP for a different indication. They use it for enuresis. They're given DDAVP either orally or intranasally, and this is a case series of 54 patients presenting with either change in mental status or convulsions. Here we have 46 patients with convulsions, and they all had hyponatremia. That was leading to all of their symptoms. Some of it was attributed to DDAVP itself causing the hyponatremia, and others was a contributing factor with excess fluid. If you're not peeing and you're drinking free water, sodium is going to go down. And so because of that, patients can be harmed. And hyponatremia can be a problem even in these patients that we're trying to correct their sodium with normal saline and DDAVP. I bring that overdose situation up because we had a patient like that in our ICU where the patient was given 50 micrograms of DDAVP instead of the normal dose of 2 micrograms. Fortunately for us, our patient didn't have any major consequences from it, but an overdose is possible. So in conclusion, we don't have much data saying how much we should raise our serum sodium in 24 hours. We don't have convincing data that we should be using DDAVP, and in addition, we don't have convincing data that it improves outcomes. So I want to open it up to discussion. I know Dr. Yi has some thoughts. Dr. Hassan, you look like you have some thoughts.
No, everything you said, really, thank you. I'll let Dr. Yi speak first, and we'll do that now.
I thought those were excellent presentations, and I applaud everybody's work.
I thought that was a good job.
I thought it was great. So first of all, let's start with the last point. 50 micrograms isn't any different than 5 in terms of renal effect. So once you've inhibited or stimulated enough receptors, the dose occurs, and that's it. You can only cause more extra renal side effects. If you mentioned more nausea, you get more nausea with 50 than 5. The second thing is, you could use it IV also. The third is, we don't know about patients that are corrected, too rapidly, that don't have severe symptoms.
Okay.
We don't know if we killed off 20% of the neurons and the person's not quite right the rest of their lives, or his life or her life, because we don't do an MRI on them. There was only CAT scan. Originally, it used to be called central pontine myelinolysis, CPM. And then they started to have CAT scans with greater resolution, go below the pons, and then they had MRI and found out that, lo and behold, it's really mostly extrapontine myelinolysis, and that's why the osmotic demyelination syndrome change in nomenclature occurred. Our problem is we forget that people's body water can be calculated. Nobody really calculates the people at risk. Now, the alcoholics may be more at risk not because they can't generate these organic osmolytes, but because they have lousy muscle mass. And it's the typical, I'm getting a liver transplantation with a creatinine of 1.2. They don't have muscle mass, and therefore they don't have space for body water, and that's why they correct so fast. There are marathon runners now. You're not allowed to get marathon runners water at the water stations. It's prescribed where they're going to be and how much you can drink, because usually females 5'2" that run real fast have this osmotic demyelination syndrome or cerebral edema. Whenever you run, they were holding all the water in their gut. They were actually gaining up to 3 to 6 kilograms from drinking water. They're thirsty, but they really don't need the water for tonicity's sake. But it doesn't change the tonicity until they stop running and then have a seizure. So all these ambulances and marathons are packed with these saline bullets of 100 mils of hypertonic saline, which they give on with almost impunity. So whether you want to protocolize this or not, if we just have more awareness of it, which I think Dr. Hassan was saying, one patient is enough to see in a lifetime, but there are a lot of subacute cases I think we want to see. We could actually do an interesting study on this and scan a lot of people. It would cost some money, and Dr. Brown in radiology might not like it, but that's his problem. The one part that's missing here is what we had talked about yesterday. The investigator that got me interested in this syndrome was from the University of Pittsburgh, was an endocrinologist, Joseph Urbalis, and he's behind most of these endocrine society recommendations. He took rats, gave them ADH in like an osmotic mini pump in the back of the neck, and so the rats have SIDH, essentially. Their sodiums are down to 100, 95, that sort of thing. Rats, by the way, keep the same normal serum sodium that you do, generally. And so he had them playing basketball. taught them how to play basketball in their little miniature court, and at 95, with adaptation, they did very well. He showed then that going up a certain degree in a 24-hour in a linear pattern, there was a threshold where damage occurred. He wasn't doing mini CT scan, it hadn't been invented yet on the rats, which is available now. But he also took patient rats and did this. He brought them up gradually. He brought some up gradually, then he brought up another group rapidly, brought them back down, but the delta in a certain amount of hours actually counts. So if a person is pouring out urine and it's very hypotonic, you probably should be treating that patient because the rapidity for a short period may be damaging. So even if you get for the average for a day to the same point, if you do it like this, that may be hurting the patient. That's all I have to say.
Yeah, I would, my comments would be that from a critical care perspective, for me, I certainly would advocate being cautious in the correction of serum sodium. Our problem comes about when patients autocorrect a little faster than anticipated. And I think that you guys have mentioned a couple of cases, and the reason I know I didn't mention any, and probably the reason that Zach and the rest of us who do critical care or have done critical care don't, is because our patients are often so complex and have so many contributing neurologic problems that identification of an issue that's related to this specifically is hard for us to know. And my problem with the kind of data that's presented in the sense of case reports, especially from the older literature when just CT scans are done, is you wonder in a complex population of very complex patients how well characterized their neurologic deficits were, and were there other contributing factors, which is why it cries out to me that what you really ideally want to have is a controlled study that compared patients who got the therapy and those who didn't, because then you might be able to tell something. I think I know, for me, again, being cautious is important, where I think we often find ourselves in differences is when there's been a minor trespass beyond the threshold, and you guys are telling us to treat, and we're saying, well, it's just a little bit over the limit, we really need to, and the patient looks okay, and I think that's where we get into the controversy.
Well, the nephrologist couldn't decide on the number either.
Yes.
I agree with you.
Well, that's what I think. So I think there's got to be some room here for us
Right.
to work it out.
This is a personal opinion.
Yeah.
That I run in both places and I see. Sometimes we are too cautious, and we're chasing. Oh, it went greater than 6. I want it just to be 6. It's 9. It's the end of the world. We have to give the DDAVP. We got to hyponatremia, and I feel the pain. Or vice versa. Now, but the issue is right. But the issue is, Eric, you can watch. Like there are certain cases that the DDAVP is not to improve outcome, but it's also to improve, my heartbeats during the next 24 hours. Let me give. If somebody's pouring 800 cc's an hour, Eric, you can say that. And all what I didn't want to use the DDAVP despite that. I said, let's give this patient D5W as long as you tell me what's the urine sodium and potassium so that I calculate the free water. For 24 hours, I'm calling from home, that value is not being obtained, okay? So if I give the DDAVP, at least I'll take the urine out of the equation, and the 3% that I give, even if the labs are not being checked, I can anticipate. So it will help in terms of the management more than in outcome. So you take the urine out of the equation, now you know exactly if the amount of sodium you're giving, what's the anticipated price, whether you're getting the serum sodiums or not. So that's what I just want to make. And being too cautious to say, I was even surprised that now they say 6. Some people have strong feelings about 6 or 8, but the most important thing for me is like that patient who was peeing. We prevented it. Instead of being from 120 to 145, we stopped at 135. It was still, beyond this 6 to 8, but nothing happened to the patient when we followed up. And if you see from the studies, most of them even overcorrect. I think they come say 6 to 8 so that you aim for 6 to 8 with the notion that it's going to come up a little bit higher.
Right. That's what Dr. Richard Stern talks about too, is that your goal should be less so that you have a little bit of a cushion.
Exactly. Like it's like saying some people come to talk to you about CVP. It's 12. Oh, or it's 14. Now it's 8. I mean, we shouldn't focus on a specific number. It's the ultimate, like cautious, but within realistic, no matter what these recommendations are, because they stem from case report.
Right.
I think that one of the things for everybody in the renal training who has a long career ahead of them is the awareness of something that Jerry said, which is that we as intensivists need to begin to look at long-term outcomes in our patients. And we have patients who survive, and from critical illness, these patients some of them may live for a while. And what we see in that population is that many of these patients have long-term disability, including neurologic disability. And the reason for that is multifactorial. But what Jerry suggested, and something that I've wondered about, and it makes you think, is do we do some of these things, more rapid correction, for example, hyponatremia, does that have long-term consequences that we're not really measuring? It's something that we don't know. And I think as you guys go through your careers, and many of you are in academic settings, I think looking at long-term outcomes of critical illness and looking at those things that we do, whether it's correcting the sodium too rapidly or some other thing, does that have effect on long-term cognitive performance and so forth? These are things that I think are really important questions to answer.
128 does, and the other big thing is reservoir for sodium is in bone. Actually, people with chronic hyponatremia may be actually getting osteopenia. 128 is the number right there.
So, do you advocate using DDAVP like you use with Eric's and chasing?
And everybody who, like when you're around with me, I only use it. So if somebody has hypovolemic hyponatremia, they're at risk to start peeing water once you give them the normal saline, or blood, or whatever.
Right.
And they might urinate in front of you. Maybe they'll only urinate 100. And if you measure the urine sodium and potassium, or the amount of free water is only 50 ml water loss, and you do the calculations how much your V is changing, I can anticipate if it's gonna how much it's gonna rise. So I don't use it in anybody. If it's becoming out of control, it's so much that even giving D5W is gonna raise, like Eric's patient, the sugar, and the nurse decides, no, it's too much sugar, I'm not gonna do it. You have to slow down the urine so that it's a more controlled rise.
Right. So you wouldn't advocate using it like in the last study that I presented, using it in every patient with hypertonic saline to create a controlled situation.
I don't use it like that, but I check the urine at the same time and decide.
Does anyone use it like that here?
But it's
the hypertonic, just like to control the lowering the sodium level if it goes beyond what you are anticipating. That's
Right.
I've had to do it once or twice in neural ICU.
Okay.
One of the things I'm getting from you guys is that we need to be vigilant about monitoring both the serum electrolytes in the urine, and that one of the places sometimes we call
Osmolality is
not giving you enough information.
right. In those who are, urinating large volumes.
Yeah.
If the patient is not urinating a lot, whether they're in that small amount, there's a lot of free water in terms of proportion or not, it's not going to affect the sodium. That's why I don't use it unless, I have large volume.
Okay. All right. Thank you.
Guys very much.
You wanna, Eric?
No, that was great. Thank you.